Hello, this is Dr. Jack Pellick from Virginia Commonwealth University in Richmond, Virginia. Welcome to this educational activity, which focuses on the management of patients with focal seizures.
The following audio is from a two-part presentation with Dr. Jack Pellick. This audio is part of a certified educational activity titled Optimizing Efficacy, Safety, and Adherence in Patients with Focal Seizures through Individualized Treatment Regimens. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/XTJ. A printable transcript, slides, practice aids, and other features are also available.
So let's look at new treatment options for focal seizures. Anti-epileptic drugs, or AEDs, represent the cornerstone of treatment for epilepsy. Since 2008, 8 new therapies for focal seizures have become available. Lacosamide, vigabatrin, ezogabine, clobazam, perampanel, eslicarbazepine, responsive neurostimulation, and brivaracetam. Most of these have been approved as adjunctive therapy for focal seizures, and a few have monotherapy indications as well. Today, I will be reviewing the efficacy and safety of these newer AEDs as adjunctive therapy, and we'll discuss the available data for AEDs as monotherapy. I will also examine important considerations that must be made for patients with focal seizures, such as factors that influence treatment selection, as well as the importance of engaging patients in the decision-making process and ensuring optimal medication adherence. Let's begin with a discussion of the efficacy and safety of these newer AEDs. First, lacosamide. Lacosamide was approved, as we said, in 2008 as adjunctive therapy in patients with focal seizures. Monotherapy indication was approved in 2014. Lacosamide is available in oral and injectable formulations. The injection is indicated as short-term replacement when oral administration is not feasible. The mechanism of action is believed to be inhibition of voltage-gated sodium channels. Studies indicated that lacosamide significantly reduced seizure frequency when used as adjunctive therapy in patients with uncontrolled focal seizures. When examined as monotherapy, the exit percentage was lower than historical control. Now that's somewhat of a different model, but historical control, rather than comparing to a placebo group, is what is now used for monotherapy studies. Let's look at lacosamide safety. In a pooled analysis of safety data for lacosamide as adjunctive therapy for focal seizures, the most common lacosamide-associated treatment-emergent adverse events were dizziness, nausea, and diplopia. Adverse effects were dose-related, with the best tolerability at dosages between 200 and 400 milligrams per day. And the incidence of adverse effects were higher during the titration phase rather than the maintenance phase. The next drug, vigabatrin, approved for refractory complex focal seizures in patients aged greater than or equal to 10 years of age. There is another indication for infantile spasms in infants. Anti-seizure effects believed to be due to irreversible inhibition of GABA, that's GABA transaminase. It is used as adjunctive therapy in patients who have responded inadequately to several alternative treatments. This is because of the adverse effects. It is associated with peripheral visual defects based on retinal toxicity. Patients are thus required to have frequent ophthalmologic examinations as part of a safety monitoring system. The next drug, ezogabine, really different. Approved in 2011 as adjunctive therapy of focal seizures in patients aged greater than or equal to 18 years who have responded inadequately to several alternative treatments and for whom the benefits outweigh the risks. These risks include retinal and skin abnormalities. It is a first-in-class potassium channel opener, so it's a new mechanism. This AED is currently being reevaluated because of the toxicity and again balancing efficacy versus toxicity. Clobazam is a benzodiazepine approved in 2011 for adjunctive treatment of seizures associated with Lennox-Gastaut syndrome in patients 2 years and above, and it is commonly used off-label for treatment of focal seizures. In a study of 183 patients with intractable complex partial seizures, previously treated with benzodiazepines, clobazam demonstrated complete remission in 61 of 183 patients. Tolerance developed in almost half of these patients within 3 months. Nearly 3/4 of the patients who remained seizure-free for the first 3 months, however, continued to be so over the next 3 months. Tachyphylaxis was not demonstrated in long-term studies of patients with generalized epilepsy, so the data is somewhat different. Adverse effects were primarily neurotoxicity. Perampanel. This drug was approved in 2012 as adjunctive therapy for focal seizures with or without secondarily generalized seizures in patients with epilepsy, age 12 and above. It is the first FDA-approved non-competitive AMPA glutamate receptor antagonist. It can be administered once daily, certainly an advantage for some. Pooled analysis of 3 phase 3 studies in 1,478 patients showed that 4 to 12 milligrams per day perampanel resulted in, first, significantly greater median reduction in focal seizure frequency versus placebo, and significant differences in responder rates were noted. Perampanel safety, the most common AEs, adverse effects if you will, are dizziness, somnolence, fatigue, irritability, falls, nausea, weight gain, vertigo, ataxia, gait disturbance, and balance disorder, if you will, the typical neurotoxicity that we've discussed with other drugs. However, there is a black box warning for serious psychiatric and behavioral disturbances which should be taken into consideration when treating patients. Eslicarbazepine, approved in 2013 for the adjunctive treatment of focal seizures. It was also approved for monotherapy in 2015. It is a third-generation member of the family of drugs with carbamazepine and oxcarbazepine as part of it. Its mechanism of action is believed to involve inhibition of voltage-gated sodium channels. Administered once daily, again, an advantage. 3 phase 3 clinical studies showed significant efficacy at 800 and 1,200 milligram doses when used as adjunctive therapy. In studies examining this agent as monotherapy, pooled exit rates were lower than historical controls. Side effect profile is really similar to other anti-epileptic drugs: dizziness, somnolence, nausea, headache, diplopia, vomiting, fatigue, vertigo, ataxia, blurred vision, and tremor. Responsive neurostimulation is not a medication, but rather a surgical procedure. Approved in 2013 as adjunctive therapy for reducing the frequency of seizures in individuals aged 18 and above with focal seizures who, first, have undergone diagnostic testing demonstrating no more than 2 epileptogenic foci and are refractory to 2 or more anti-epileptic medications. Vagus nerve stimulation is also available, and it was approved back in '97 as adjunctive therapy for patients older than 12 years who indeed had refractory focal seizures. And I add this because this and the responsive neurostimulation are, if you will, surgical inhibitory procedures as opposed to the medications, but are new ways of treating epilepsy. And now our newest drug, brivaracetam. Brivaracetam was FDA approved in February 2016 as adjunctive treatment for focal seizures in patients aged 16 years and older. It soon will be available. It is an analog to levetiracetam with a similar binding site on synaptic vesicles. Significant reductions in seizure frequency and increases in patients showing greater than 50% reduction in focal seizures were observed through 3 phase 3 studies. Treatment is initiated without titration, an advantage for some persons, meaning that patients really can start at the dose that they may remain at from the first day of treatment. Most commonly reported AEs with treatment were, again, somnolence, dizziness, headache, and fatigue. Sounds familiar? These are all anticonvulsants. They all work on the brain. It would be expected that we're going to see some of these same side effects. So as you can see, newer AEDs are almost always approved as adjunctive therapy because of the way that trials are conducted. Current FDA standards require superiority trials for monotherapy because really placebo-controlled studies are considered unethical to keep somebody off medications while they're having active seizures. The first generation AEDs were grandfathered by the FDA and received approval for monotherapy for a particular seizure type without condition to safely satisfy current rigorous approval requirements. Currently, lacosamide and eslicarbazepine, as you have seen, are the only third-generation AEDs with both monotherapy and adjunctive therapy indications. But levetiracetam and pregabalin are currently under investigation for monotherapy. So let's discuss monotherapy versus polypharmacy. AED polytherapy has the potential of course, to improve seizure control and possibly achieve higher rates of seizure freedom than monotherapy alone. However, you pay the price. First, the extent to which AED combinations in practice provide superior seizure control appears variable across studies. And there are concerns regarding overtreatment, or if you will, increased drug toxicity or paradoxical increases in seizure frequency that come from adding more than one drug. The adverse effects typically increase, and pharmacokinetic interactions may become more frequent as you have 2 and 3 drugs versus 1 drug. If you will, the drug burden is increased. Other drawbacks include difficulties in determining individual drug actions, more complex dosage regimens, poorer treatment compliance, and increased treatment costs. Monotherapy really is preferred. That's why we start with it. We start with 1 drug at a time, and to see if we can in fact control somebody's seizures with just 1 drug at a time, and frequently up to 50%, we're going to be successful. It's more convenient, it improves adherence, improves quality of life, reduces the risk of serious adverse effects, minimizes drug interactions, and decreases costs. So a conclusion, if you will, so far we have reviewed the data for newer AEDs when used as adjunctive treatment and as monotherapy. Only a few AEDs have monotherapy indications, but it is a goal that we should all strive to get back to 1 drug that works for our patient, if that's possible. Stay tuned for the next segment, where I will talk about important components of the management plans of patients with focal seizures, including factors that influence treatment selection and strategies to optimize medication adherence. Let's now talk about important considerations that must be taken into account when developing treatment plans for patients with focal seizures. The goal of seizure therapy is to produce seizure freedom without adverse effects and to maintain or restore quality of life. Overall, our approach is standard to a certain degree for treatment of epilepsy. We begin with monotherapy with an initial AED. If the patient does not respond to the initial monotherapy, either because seizures continue or there are intolerable side effects, we typically proceed with monotherapy with a second AED. If seizures continue, even with this second AED monotherapy, the next step in treatment would typically be putting 2 drugs together for polypharmacy. There are a number of practical considerations, however, when considering which drug to pick, which to combine. First, patient factors like seizure type and syndrome, personal preference, age, gender, pregnancy potential, comorbidities, co-medications, and individual lifestyle. For example, can they take more than once daily dosing? AED characteristics include the spectrum of efficacy, mechanism of action, indications, monotherapy, children, age restrictions, what have you, tolerability and safety, neuropsychological implications, dosing frequency, titration complexity, simplicity of use, drug-drug interaction profile, of course, teratogenic potential, and availability, cost, and reimbursement. Well, let's look at polypharmacy or polytherapy versus continued monotherapy. What are the reasons for adding versus switching? The reasons to add: inadequate control. That's usually the number 1 indication. You've gone through your 2 sequential monotherapies and you still don't have seizure control, so one attempts then to use 2 drugs together. It turns out actually that we usually cross over, and that you start a first drug, and unlike, say, an antibiotic therapy where you stop one and start a second, we will cross over somewhat and continue to reduce that first drug. And it's important to reduce that first drug to give the second monotherapy trial a real chance. So, did they tolerate the first AED? Were there any anticipated drug interactions? Patient is risk averse. They really don't want to take the consequences of seizure exacerbation, and they need to discuss this more. Perhaps the first AED was appropriate or not appropriate, and one needs to go back and reinvestigate this. Did it give us partial control? Was it not pushed high enough? The reasons to switch AEDs: patient not tolerating the first AED had disadvantages, drug interactions were expected, pregnancy was anticipated, and seizure exacerbation, well, not likely. When we select patients then for conversion to monotherapy, in patients receiving polytherapy, we should always be thinking about titration, reduction, and moving towards monotherapy. Potential candidates for conversion to monotherapy include patients who achieved seizure freedom on combination therapy. If they're not seizure-free, I think one has to sort of say, is it really going to be an advantage to go to monotherapy? Sometimes it is, but I think one has to think through this carefully. Seizure control really should be relatively easily obtained, and seizures should not be too severe. Patients with a history of fluctuating symptoms may find polytherapy beneficial during exacerbations, but monotherapy preferable during periods of remission. Now, as we all know, epilepsy is a paroxysmal disorder with ups and downs, but there are times in certain person's life where for a month or two or some circumstances just have given them an increase in seizures, a short-term polypharmacy or adjunctive therapy is advised, but then should they stay on that forever? And these are people that need to be considered to come back to monotherapy. Patients who have had few adverse effects with monotherapy, but who have had compounded adverse effects with polytherapy, may also be good candidates to consider for conversion from polypharmacy to monotherapy. There are also many lifestyle factors to consider. For example, if a patient is entering school or university, taking polytherapy may be more difficult for them than when they were at home and they were being reminded to take their medications on a regular basis, and probably getting more sleep on a regular basis. The risks of seizure-provocative events, such as staying up all night, must be discussed with the patient. One needs to get regular sleep on a regular basis. If a patient is considering pregnancy, conversion to monotherapy should be considered, certainly. You should inform the patient that when planning such an approach, you want to have probably about 6 months of monotherapy before they get pregnant. If somebody needs to drive, then they may not be able to afford the risk of having a seizure in a conversion to monotherapy process, and should probably continue to receive polytherapy or agree to say my driving is going to be reduced or absolutely decreased to zero for some period of time that's agreeable to patient, physician, and others making that decision or helping make that decision. If you are taking a patient who is seizure-free on polypharmacy and converting them to monotherapy, everybody involved must be aware of the risk of this treatment change and the possibility that this will result or may result in a breakthrough seizure. Deciding which AED to remove requires careful review of history and discussion with the patient. The physician must be knowledgeable about AED pharmacology. Some of the AEDs that we use frequently exert effects on liver enzymes and other metabolic effects. If those are the medications that will be withdrawn, then the second anti-epileptic medication may actually undergo some changes in its metabolism. The importance of optimizing AED selection has a lot of considerations, and I think, let's call it adherence. Another issue that we must consider is adherence. Are patients going to take medications as prescribed, and why do they not? Non-adherence to drug regimens is associated with worse medical outcomes and increased costs. There are more emergency department visits, more hospital admissions, more anti-epileptic drugs at higher doses, poorer work performance, and higher disability payments. Why don't people with epilepsy take their medication? Well, some people point blank don't think they have epilepsy or don't think they have it anymore. Commonly, kids go to college and say, I'm doing so well, and it's just not epilepsy. It's many disease states. I'm feeling well, I'm doing well, I'm not really sure I have it anymore, and they stop their medication. This is not just limited to adolescents, it's many other folks too. So they don't want to have epilepsy, or they don't want to have the disease. They don't like taking their pills just as a principle of taking them every day. They don't like prescribed medication. They don't understand the need for the treatment. The drug schedule is too complicated or rigid, and they, perhaps disorganized, unfocused, and forgetful. So what can clinicians do to improve adherence? Discuss history, diagnosis, investigations, and prognosis in detail with patient and family. Provide written material. That's really important. Give plenty of time for subsequent discussions and answer all questions slowly, honestly, and carefully. Allow everyone enough time to come to terms with the diagnosis, results of the investigations of the treatment, and prognosis. Choose the best treatment with specific focus on matching the side effect profile to the patient's lifestyle and clinical history. You must involve the family in the management plan. We can provide a dosing box for patients in whom adherence is an issue. Check plasma levels when indicated. When are they indicated? Well, what's changed? Was there a seizure? Were there side effects? Are we just doing them regularly? Or are we going to do them now and then? Ask specifically about individual side effects such as dizziness, sedation, aggression, depression, and if the patient doesn't take the medication, point blank, it doesn't work. So let's talk about some other strategies and the role of shared decision-making in management of patients with epilepsy. The concept of shared decision-making includes greater patient collaboration with physicians regarding management decisions. And that's what we're really talking about. We're talking about bringing everybody together to make the decision. Shared decision-making is applicable to situations where several acceptable options exist, such as the choice of anti-epileptic drugs, a treatment in pregnancy and medication withdrawal. The benefits of shared decision-making include improved decision quality, more informed choices, and better treatment adherence. And decision aids, which help patients understand the pros and cons of available options, can assist in shared decision-making. So in conclusion, treatment options for patients with focal seizures have expanded significantly in recent years. When initial treatment is ineffective, decisions regarding whether to add or switch therapy depends on a variety of factors. Monotherapy remains the preferred method of treating patients with focal seizures. In fact, it's the gold standard. And it's for various reasons, including fewer side effects, decreased costs, more convenience, and increased adherence. Tapering of one or more AEDs can be successfully accomplished in many patients receiving chronic polytherapy. Shared decision-making can improve the quality of treatment decisions as well as medication adherence. That ends our discussion for today. I hope you found it informative and useful. Once again, I encourage you to download the slides and practice aids for the activity. Don't forget to access post-test and evaluation form by clicking the red Get Certificate button. Thank you very much for participating in this educational activity focused on the treatment of focal seizures.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/XTJ. This activity is supported by an educational grant from Synovion Pharmaceuticals.